All right, well, welcome everyone who's been able to get on with us. I hate it that we're having a little bit of connectivity issues, but we'll get there. Um, my name is Sarah Wolford. Welcome to the VCCA Healthcare Sustainability Committee. We are so grateful that you guys are here with us. This evening, we have a special guest at the top of our hour, Dr. Peter Trinh. Dr. Trinh is an internal medicine and primary care resident at Brigham and Women's Hospital. He's a 2022 Healthcare Without Harm Blair and Georgia Sadler Fellow and helps to lead his internal medicine residency program's Climate Change Action Committee. There, he has been working to build and sustain a climate-smart culture by reducing low-value, wasteful clinical practices and raising awareness of healthcare's role in climate change. He attended Princeton University and received his medical degree at Rutgers Robert Wood Johnson Medical School and his business degree at Northwestern's Kellogg School of Management. And we are so grateful and so lucky that he's here with us tonight. So I'm going to pause there, and Peter, you can take the screen. And thank you for joining us.
Thank you for having me and giving your time up tonight for this important cause and giving me this platform to share my work. Some of the work I've just been doing on the side in residency. And this is the stuff I'm going to talk about tonight. It's the same content that I delivered at Clean Med back in May. If some of you were there, you may have seen me like Sarah. And so there's just a little updated stuff to that in case you did see that talk as well. But I'm going to go ahead and share my screen. And so that way you guys can just see it. And let's see. Okay, so the title of the talk today is going to be Integrating High-Value Care and Environmental Sustainability, and it's a resident project to reduce unnecessary labs. So the background to this is that, like, as Sarah mentioned, like I came from went to like an Ivy League undergrad, went to Rutgers for med school, and then I was lucky enough to match at Brigham for residency. And like in my mind, I was like, oh, it's a Harvard associated like hospital. Like I was taught in med school that we need to be practicing high value care, and like this place is definitely going to do it and put it into practice. And I get there and it's not that at all. And so I was just like, oh man, this is like, yeah, it was kind of a letdown. And so I wanted to try to do something about it. And so at Brigham, we have this culture where kind of labs and de-escalating labs are second thoughts. And in this coming day of age where sustainability is becoming more prevalent in everybody's lives and environmental impact and whatnot, I think it's important that we start doing this kind of work and making it more top of mind within healthcare. So this work is definitely not new. Like there's definitely been a lot of other resident projects published and not published around the country, I'm sure. These are just three that I've referenced before. One is this study that actually just came out pretty recently, coming out of either Northwestern or WashU. This one was some UCSF residents, and this one was some Maimonides residents in New York City. They each kind of had their own unique bend to it. One was about high value care, like similar to mine. These residents at UCSF approached it from a patient experience standpoint. And then these individuals in New York City want to just educate their co-residents on the actual clinical indications for labs. And so my primary goal for my project was, of course, to reduce unnecessary labs. These were the labs that we decided to focus on because they're the most commonly ordered labs in our hospital. But more importantly to me, these secondary goals were pretty much on par to me with the primary goals. And that was the idea of trying to link environmental sustainability with high value care. High value care, like the equation thrown around, right, is like patient experience, high quality care above a denominator of low cost. And as like we're educated in that formula, and environmental sustainability is still not part of it. And I wanted to try and make that link for my co-residents, and so that they can factor that into their decision making. And then, of course, with any intervention we do, anything we want to try and change, we want to create that behavior change, provoke it, and then sustain it. So that I was thinking a lot about that and how to sustain the desired behavior, and then through sustained behavior change, try to begin nurturing that culture at my residency. So having gone over the goals, the actual intervention itself that we worked on was we have at my residency this like special general medicine unit called the integrated teaching unit, which is like larger resident team. There's like five residents per team. And it's a lower patient load too. So there's ideally more time for teaching. So we piloted this project on this unit. There was an A team and a B team, and we decided that there's one team would be the intervention team and the other team would be the control team. We gave a video to educate people to the intervention team at the orientation at the beginning of their month-long block. So this was a team that was able to form and storm and grow together over a month and hopefully implement this behavior. And the behavior specifically was doing daily end-of-day team reviews of their patients' labs and coming to the decision of de-escalating labs together as a team. So I actually want to take the time to show you the orientation video. It's a short 2 to 3 minute video, and I think it's informative to show you the bend that we took. This is a co-resident of mine. She's great. She just graduated. Her name's Kin, and now she's out in California doing great things.
Hey everyone.
But this is the video.
And I'm one of the residents working on a project to decrease the number of unnecessary labs we order on the wards. One of the reasons I got interested in this project is after learning that at the Brigham, as of data from a couple years ago, patients get 1.6 blood draws per day versus once daily at MGH. It made me start wondering whether all these extra lab tests were actually necessary. Does it advance patient care? And what are the harms? As I looked into this, I found that 20 to 30% of healthcare costs are wasteful, and specifically, we spend between $17 and $28 billion every year on low-value screenings, testing, and procedures. The American Board of Internal Medicine launched the Choosing Wisely campaign to decrease low-value care. They collaborated with around 60 professional societies to come up with more than 500 recommendations on reducing waste and avoiding unnecessary tests and procedures. The Society of Hospital Medicine published a list of the top 5 tests they recommend avoiding and specifically called out lab tests, saying, don't perform repetitive CBC and chemistry testing in the face of clinical and lab stability. It's important to remember that ordering lab tests are not benign. Reducing repetitive labs can minimize patient harm by reducing the rates of hospital-acquired anemia, preventing wasteful cascades of care, decreasing costs, and improving patient satisfaction. There also can be significant environmental co-benefits from eliminating routine labs, such as reducing plastic waste and decreasing the carbon footprint of running extra tests. Thinking about the environmental costs of the tests we order is really important. The US healthcare system generates 10% of all the greenhouse gases generated in the country. If the US healthcare system was a standalone country, it would rank 13th greatest greenhouse gas producer in the world, just ahead of the United Kingdom. So, what should you do? Before ordering lab tests, ask yourself, do I need these labs today? Is it answering a pointed clinical question? Will it help with diagnosis or management? Is the patient deteriorating? If you answer no to all of these questions, then you probably do not need to order that lab. If you have any questions or concerns, though, you should absolutely talk it out within your team or ask your attending. Thanks so much for listening.
So that's the video. It was nice and short, but hit kind of all the highlights of why we should be doing this kind of work and doing and de-escalating labs. Oops, there you go. So moving on in terms of, we had this orientation video, and as I mentioned before, kind of provoking and sustaining that behavior change was really top of mind for me and my team. And so the thing we definitely try to focus on was getting buy-in from our seniors, being senior residents and attendings. We had done a pilot version of this back in like fall 2021, and just involving that video and not the team-based behavior. And we surveyed our residents, and they showed that like without having the top-down induced kind of push, people were really afraid, especially interns, of taking the initiative of de-escalating labs. Basically, they did not have that psychological safety. And then one of the things I learned in terms of trying to sustain behavior change at my time in business school, one of the only things I learned, I feel like, was that under communicating when you're trying to do behavior change work is a key error. And so I'd really try to keep that in mind too, and send out multiple emails per week to each of the team members. And so even though people have email fatigue is real, these emails were just the subject line and one line in the body. And the point of them was just so that even though the residents would probably delete them after like 2 seconds, that at least it shows up in their mind that like, oh, this is the de-escalation lab email. Let me try to remember that. And the repetition of it kind of hopefully lodges it in their brain. And so we did pre and post surveys of our residents who participated in this. Each arm, the control arm didn't get the survey. It's really just the intervention side that we surveyed. And this was about a body of 30 residents over 6 months. And so we had an N of about 23, which is pretty good, I think, for survey responses. And we wanted to understand their perception of the culture first as part of the one component of the survey. So this was a simple agree, disagree statement. Do you think the residency culture embodies high-value healthcare? And blue is pre and orange is post. And you can at least see that there's a trend towards more people agreeing post-intervention that the culture is more in line with high-value healthcare principles. This is not statistically significant. We didn't do a statistical analysis. The end is pretty small, but that signal is there, and that's what we really like to see. There's this other statement then, kind of the opposite. Is there a cultural expectation to maintain lab orders? And thankfully we saw a small signal, of course, that the N is like there's three more residents that disagreed with this statement after the intervention. But there's that shift in perception. And then what was really important to me was whether or not my co-residents felt supported as a result of this initiative to go ahead and de-escalate labs. And this slide to me is very heartening because it shows that after the intervention, there was only one person out of all those, out of like 23 surveyed, that's thought that they did not feel safe or supported de-escalating labs. So everybody else, there was this felt safe. There's this team culture where people were supported. So that was important to me in terms of getting an important cultural signal. We also wanted to survey the actual perceptions of their actual behavior itself. Did they think they were actually behaving in a way that was in line with de-escalating labs? We asked them, do you agree with I maintain clinically unnecessary lab orders? Post-intervention, there's more orange in the disagree side, which is a positive signal as well. We then asked them about the specific behaviors related to de-escalating labs. So the first step is reviewing and assessing the labs. And you can see that post-intervention, there's way more residents in the at least once daily and then multiple times per week column than the once weekly than less weekly. This kind of shows that our intervention kind of failed because there's not a big column in at least once daily, which is what we wanted, but it's a fantastic signal to us still because there's way more people checking labs more often, and that's what we wanted. And then the second order level of behavior is after reviewing and assessing, how many people are actually taking the step of decreasing the frequency? So not yet canceling the labs, but at least spacing them out to every other day or a few other days. And you can see the same kind of trend as you did in this slide, where there's more orange in the multiple times per week column, and the same in here as well. And then the final third order is how often do you think you actually discontinue labs? The same trend, at least, with more people discontinuing labs multiple times per week. So all of that cumulatively shows to me and my team that there's a great positive signal here, at least culturally and in terms of self-perception. One final question we did ask them was which factors motivated you the most to try and de-escalate labs? And based on the updated data, environmental sustainability came in number 4, which I'm fine with because the first 3 factors are are appropriately first. There's just lack of clinical indications, and then the patient-centered outcomes of experience and safety. And I'm happy to see that environmental sustainability beats out like financial savings. I did wish the expectations of team members went up higher, but nothing can be perfect, right? And so one other thing, if I have, do I have time, Sarah? Quick, yeah. One other thing, so to show you actual, just like a little bit of quantitative data behind the actual lab volumes. This is based off some an incomplete data set. Unfortunately, I'm working on getting it complete, but just the way it's coming out of the enterprise warehouse data warehouse is not right. So we still working on getting kinks out of that. Some of the flaws we're getting is that for some reason, for some patients, like the demographic data is not even coming out right. So we're working on that. But you can see that like the graph is a little confusing because it's my partner in this project is put it at the y-axis in percentage of patient days, and it gets a little confusing to interpret. But I would just focus on this for now on the table in which it shows ITU-A, which is our control, ITU-B is the intervention. There's at least for the basic labs that we assessed, we wanted to see if there's actually statistically significant differences in the numbers of those labs ordered. And for magnesium phos, LFTs, CBC, PT, there's all statistically significant differences between intervention and control. The only one that shows like in which there's more labs ordered between B, the intervention, and the control is this phosphorus group. But for all the other ones, for MAG, LFT, CBC, and PTINR, there's statistically less labs ordered. The BMP is not statistically significant, and I'm not surprised by that because everybody always wants to like at least know that the kidneys are doing okay. And so I think that makes sense culturally that people are less likely to de-escalate that lab last, or more likely to de-escalate that lab last. But as you can see, like if you look at the absolute numbers, like they're very small, but this is for a group of 30 residents over 6 months. And if this is a small part of our residency, and if you magnify that or multiply that out over all the residents over time, that would lead to some pretty significant changes and differences, I think. And yeah, so that's all I have for you guys today. Hopefully I kept you engaged and weren't too bored by the data at all, but would be happy to answer any questions that you might have.
That's amazing. Thank you so much, Peter, for sharing this information. I even heard more new things. I did see you at Clean Med, and you were fantastic at Clean Med, and I just learned so much again, once all over again. So thank you so much. It's wonderful. I have a few questions. Samim or anyone on the line have any questions for Peter?
I can kick off the first one while folks are thinking of some questions. Peter, I was wondering if you had thoughts of expanding your, I guess, target population. This was primarily residents. Is there, just kind of speaking from my experience, I find that, at least in the emergency department, we often do a little bit along the lines of trending of labs. Mainly it's lactate, sometimes troponin as well. But I really find it to be pretty empowering when my nursing colleagues are able to just cancel the repeat lab because they know what they're looking for, and that repeat is no longer necessary because their initial troponin was negative, or even the initial lactate was definitely negative. What are your thoughts about including nursing colleagues into this?
Yeah, long-term nursing APPs are absolutely necessary for this work. I think we're in a little bubble in residency, and so expanding outside of residence is absolutely within like my goals. It's really interesting to hear that for you, Samim, that your nurses are empowered to like be able to cancel labs. Like ours are not. Like they would just see it and then do it. So that's actually really interesting to hear structurally at your institution that they're empowered to do that.
Okay. I have, if no one else has a question in this moment, I don't want to speak over anyone. I have a question actually from Abigail, who sent this question, and she said, I've been on internal medicine teams before where there have been pushes to stop daily labs. Do you think linking to climate messaging helped strengthen the message?
I do. Yeah. I think most people, when I've just like had my informal conversations with some of the residents on the team, they reference really the environmental part because they've always heard the cost savings parts, the patient experience part, but what sticks out to them because it's new is the environmental piece because they don't think about that. Well, for most people, at least, they don't think about that at all. So I think leveraging that because it's new, it helps it stick in the mind. And if there's someone who is like, they think that's important, that actually then that sticks. Yeah. If there's someone who's already like green oriented.
Mm-hmm. Mm-hmm. Yeah, you mentioned, I made a note earlier, you mentioned, when you were kicking off about linking environmental sustainability to high value care. And I thought, my gosh, I just haven't done a great job of that in my healthcare system. I mean, we do a lot of work around clinical efficiency, but I haven't, it's been a minute since I've really focused in on that. And that is so important right now, and so I really appreciate that insight. I had another question for you, if you don't mind. Hold on.
Mm-hmm.
I've lost it here. So I wonder when you were doing this, when you kicked this off, was this like just a you idea? Did you link up with quality or did you have to go through the IRB? I mean, who was on your team to get this done?
So I reached out to some attendings and they connected me with co-residents, like the co-resident who made that orientation video. Who happened to just be, it was very actually convenient. We did have to go through an IRB as well to do this, but it was because the patient data is like, it's all confidential now. We don't actually pull or we scramble all we de-identify all the data on the final analysis. It qualified under expedited IRB. So it didn't actually require much, like it's not too onerous from that standpoint. Mm-hmm. But having support, from like since medicine's top down, like having that upper level support from the attendings who are sponsoring me, and they happen to be connected with program leadership and like the leadership of the ITU, they were really, really important for this, I think.
Mm-hmm. Mm-hmm.
Yeah.
That's great. It's a great project.
Yeah, thank you.
Any other questions for Peter?
If not, Peter, thank you so much for your time. And we know you're having your committee meeting at your home with some of your co-residents coming by, which makes me miss residency time. So I'm glad you guys are able to come together and chat about this in person.
Yeah, thank you. And just want to say also congratulations. I know this is a relatively new committee yourself, so I want to congratulate you on coming together and working together on this really important work. So yes, I hope to hopefully collaborate on something in the future with you guys and see you at Clean Med in the future as well.
Yes, absolutely. We'll see you there. Thank you so much. We really appreciate it.
You're welcome. Have a good night.